All right, let's dive right in, shall we? Today we're attacking a topic that's been a hot debate in critical care for years: the timing of renal replacement therapy in patients with severe AKI.
Oh, yeah, this is a big one. And we've got some really interesting research to dig into, especially the AKI 2016 study. It really shook things up.
It definitely did. But
Okay.
before we get too deep into the leads, I think it's important to take a step back. For those who might not be as familiar, can you give us a quick rundown of what AKI is and why it's such a concern, especially in the ICU?
Sure thing. So, AKI, or acute kidney injury, it's basically when your kidneys, those amazing filters that keep your blood clean, suddenly decide to go on strike.
On strike, huh? That sounds serious.
It can be, especially when it's severe. Think about it. Your kidneys aren't doing their job, waste products start building up, and things can go south pretty quickly.
Yikes. So that's where RRT comes in, right? Like a lifeline for the kidney.
Exactly. Renal replacement therapy, or RRT, it's like a backup system when the kidneys can't handle things on their own.
Okay, that makes sense. Now let's talk about this AKIKI study that everyone keeps buzzing about. What makes it so special?
Well, for one, it's a huge study, a multicenter randomized controlled trial with tons of ICU patients from all over.
Wow, so a real global effort. And what were they looking at exactly?
They wanted to see if starting RRT early, like within 12 hours of meeting certain criteria for severe AKI, would lead to better outcomes compared to waiting a bit longer.
I see. So like a preemptive strike versus waiting to see how things play out. I can
Um,
see why that would be a hot topic.
oh yeah, for years, many clinicians believe that earlier was always better. Get those kidneys some help ASAP. But the AKI-KI results, well, they were a bit of a surprise.
All right, spill the beans.
Huh?
What do they find? Did early RRT win the day?
Actually, no. The study found no significant difference in 90-day mortality between the early and late RRT groups.
Wait, so starting RRT early didn't actually improve survival rates?
That's what the study showed.
Hmm, that's pretty unexpected. So does this mean RRT is pointless? Should we just throw in the towel?
Hold on there. Not so fast. It doesn't mean RRT is useless, not at all.
Okay, good, because I was starting to get a little worried. So if it's not a simple early's always better situation, what's the takeaway here?
I think the AKI-KI study really highlights the importance of individualized care. You can't just have a one-size-fits-all approach to RRT.
You're saying we need to be more thoughtful, more tailored in our approach.
Exactly. Every patient is different, and we need to consider the whole picture before jumping to conclusions about when to start RRT.
Okay, I'm starting to see where this is going. It's about looking at the individual patient, not just following a rigid protocol. But how do we do that? What factors should we be considering?
Well, there's a lot to think about, and I think that's where the real meat of this discussion lies.
You've piqued my curiosity. But unfortunately, we're out of time for this segment. We'll dive deeper into those factors and more after a quick break. Okay, so we've talked about the AKIKI study and how it really threw a wrench into the early RRT is always better idea. But where do we go from here? You mentioned there are a lot of other factors to consider when making decisions about RRT. Can you break that down for us?
Absolutely. Like I said, it's all about personalized care, right? We need to look at the whole patient, not just their creatinine levels.
Right, because as we know, creatinine can be a bit of a lagging indicator. So what else should we be paying attention to?
Well, for starters, we need to think about the underlying cause of the AKI. Is it sepsis, heart failure, maybe some kind of obstruction?
I see. So the root of the problem can really guide our approach.
Exactly. And then, of course, we need to assess the patient's overall condition. How stable are they hemodynamically? Are other organs involved?
So it's like a big puzzle. We need to see all the pieces before we can decide how to proceed. What about things like the patient's age and comorbidities? Do those play a role?
Absolutely. Age is definitely a factor, as is the presence of other chronic conditions like diabetes or heart disease. These things can impact how well a patient tolerates RRT and what their overall prognosis might be.
This is getting complex. I'm starting to feel like we need a supercomputer to crunch all this data for us. Speaking of technology, what about all the advances in RRT itself? Are there new modalities or techniques that are changing the game?
Oh, there's definitely a lot happening on that front. We're seeing more and more interest in continuous RRT modalities, especially for patients who are hemodynamically unstable.
So instead of the traditional intermittent hemodialysis, we have gentler options that might be better tolerated.
Exactly. Continuous therapies like CVVH and CVVHD can be less stressful on the body, which can be crucial for someone who's already critically ill.
That makes sense. And I've also heard about some newer techniques like chemoperfusion. What's that all about?
Hemoperfusion is pretty cool. It's a way of filtering the blood using special cartridges that can remove inflammatory mediators and toxins.
Oh, so it's like taking out the bad guys and giving the body a chance to heal.
Exactly. There's a lot of research still being done, but early results are promising, especially for certain conditions like sepsis.
Wow, this is all so fascinating. It seems like the world of RRT is constantly evolving. Where do you see things heading in the future?
Well, I think we're moving towards a more data-driven approach to AKI management. Imagine having access to a patient's complete clinical picture.
You mean like their medical history, biomarkers, hemodynamics, even genetics?
You got it. All that data could be fed into sophisticated algorithms that could help us tailor RRT strategies for each individual.
That sounds like something out of a sci-fi movie.
Yeah.
But you're right, with all the advances in technology and our understanding of AKI, it's not that far-fetched.
It's an exciting time to be working in critical care, that's for sure. But even with all this amazing technology, there's one thing we can't forget:
And what's that?
the human element.
Ah, you're so right. No matter how fancy our technology gets, we can't lose sight of the patient as a person.
Exactly. It's about using our clinical judgment, our experience, and our empathy to make the best decisions for each individual.
Well said. I think this deep dive has given us a lot to think about. The AKI-KI study really challenged our assumptions about RRT timing, and it's clear that there's still so much to learn. But I think the biggest takeaway for me is that we need to stay curious, stay informed, and always be willing to adapt our approach based on the latest evidence.
Couldn't agree more. The world of critical care is constantly changing, and we need to change with it. So keep asking questions, keep learning, and keep striving to provide the best possible care for your patients.
Absolutely. And on that note, I want to thank you for sharing your expertise with us today. It's been a truly enlightening conversation.
The pleasure was all mine. Thanks for having me.
And to our listeners, thank you for joining us on this deep dive into the fascinating and complex world of RRT timing in severe AKI. Until next time, stay curious.